of Medicine, Neurology Fellow. Our very keen neurointervention, Dr. Leong Yu Yang from the Department of Radiology, Professor Dr. Muhammad Sharif Muhammad Said, Ketua Unit of Rheumatology, and I will be the moderator for this session. Okay, so without further ado, we'll invite Dr. Farhan to start. Thank you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning to Prof. Nafisa, Head of Department, and to all the professors, consultants, specialists, and my fellow colleagues. So thank you for giving me the opportunity today to share a case on seizures in a young woman. So we have here a 38-year-old lady with a background history of morbid obesity with a BMI of 43 and a history of post-encephalitis epilepsy diagnosed since 2002 and bipolar mood disorder. And she was on TAP lamotrigine 25 milligram twice a day, TAP risperidone 2 milligram on night, and TAP sodium valproate 200 milligram daily. So she presented to the casualty with several episodes of generalized tonic-clonic seizure for 1 day prior to the admission. So the seizure were preceded by a prodrome of a week of headache and fever, followed by 2 days of reduced responsiveness, incoherent speech, and forgetfulness. She was previously well controlled on sodium valproate prior to this admission, and she was brought to the ED by her family members. So upon arrival, she was confused with a GCS of E3V4M5, with a blood pressure of 166/79, pulse rate of 73 beats per minute, and temperature of 36.9. Neurological examination revealed no neck stiffness, but shows left-sided hemiparesis. So to recap the salient features on the patient presentation, this is a young lady who is obese, a known case of epilepsy, presented with a prodrome of 1 week history of fever, headache, altered sensorium, acute duration 1 week, and 1 day prior to admission, she presented with multiple GTC episode. And on neurological examination, shows a left-sided hemiparesis. So baseline investigation on arrival, full blood picture shows a mildly elevated white blood cell of 11.5 with a normal hemoglobin and platelets. Renal function showed normal electrolytes. Liver function also showed normal liver function, as well as the urine FME, no significant abnormalities detected. And the plain CT brain showed left frontal intracerebral hemorrhage. So based on the key features mentioned just now, I try to recap again, is an obese young lady with a known case of epilepsy, came in with a 1 week history of fever, headache, altered sensorium, and then presented to the casualty with a multiple episode of GTC. So what further information I would like to know in terms of how I approach this patient as a first medical contact. So in terms of the history taking, I want to know whether there's any history of head trauma preceding the seizure, and most importantly, whether the patient compliance to the previous anti-seizure medication. I want to know about the previous seizure semiology and what types of seizure the patient presented with last time, any video telemetry done or any previous EEG done to see the patterns of the seizure. And on top of that, any history of illicit drugs or substance abuse, any recent travel history or any sick contact prior to the symptom. And most importantly, in young ladies who presented with a seizure, I would like to explore more on any connective tissue disease symptoms, such as any joint pain, any rashes, any alopecia or ulcers. And most important also, part of the history taking in a reproductive age female. I want to know more on menstrual history, any previous pregnancy outcome, any miscarriages, and any use of oral contraceptive pill, and any bleeding tendencies, unprovoked bleeding. And family history, I would like also to know any history of young hypertension run in the family, or any family history of renal failure. For example, autosomal dominant polycystic kidney disease. So in terms of physical examination, I would like to know what are the capillary sugar upon arrival, because I want to rule out any metabolic abnormalities which can mimic seizure, and how was the blood pressure trend in the past, any differential differences in the upper and lower limbs which may suggest vasculitis of the large vessel. And in terms of the character of the pulse, whether the pulse is regular rhythm, and the volume of the pulse. And bedside examination of fundoscopy to look for any retinopathy changes or any papilloedema. In terms of general skin examination, we'll look hard for any rashes, any oral ulcer, any non-scarring alopecia, or any neurocutaneous stigmata to suggest neurofibromatosis. And in terms of joint examination, any joint deformities of any synovitis. Abdomen examination, I would like to examine whether any ballotable kidney or any mass or any bruit. And cardiovascular examination, I would like to know whether any murmurs heard or any stigmata of infective endocarditis. And lastly, any palpable lymph nodes over the cervical or any inguinal or any axillary lymph nodes.
Okay, thanks, Dr. Farhan. So based on this examination and the history, all right, do you have a few differential diagnoses that will go through your head prior to doing all these tests?
Again, the salient features on the patient presentation is a young lady, known case epilepsy, with a 1-week history of altered sensorium, fever, headache, and also came in with a multiple episode of GTC. So in an acute presentation, I would like to put number 1 as an infective cause of the seizure, namely like meningoencephalitis as a primary diagnosis.
So we will let Dr. Tan to get the further history.
Okay, so thank you, Farhan, for the extensive history taking and also clinical examination. So I'd like to add on to whatever Farhan has asked and answer directly. Basically, she's a patient who's got no history of head trauma. She has got quite poor compliance to ASMC. She's not been taking it for quite some time, in fact, and she's defaulted her neurology appointment over the past few years. The current semiology is similar to the previous ones. Basically, in this presentation, she's got a generalized clonic seizure, which has affected both upper limb, with uprolling of eyeballs as well as urinary incontinence for about 3 short episodes, in which she did regain consciousness in between. Aside from that, actually, the past history is quite uneventful. She didn't have any significant family history as well. She denies any use of illicit substances, and there were no recent travel history. Her last EEG done was about 4 to 5 years ago, and that did not show any abnormalities, and there was actually no video telemetry that was carried out. She didn't have any connective tissue symptoms. Menses was regular, and she had a history of miscarriage once at the first trimester. Otherwise, she's had 2 healthy children at the time being. Moving on to the clinical presentation and examination, her capillary blood sugar ranges between 5.2 to 7.4 millimoles per liter. Blood pressure shows a systolic blood pressure of 138 to 169. And diastolic blood pressure is around 79 to 96 millimeters of mercury. Heart rate is around 70 to 90 beats per minute, which is of regular rhythm. There is no obvious stigmata of connective tissue disease, and otherwise there was some ecchymosis over her forearm, but that is more likely due to blood taking. Our ophthalmology colleagues has assessed the eye with a fundus examination, and there was no abnormalities seen. And otherwise, no focal neurological deficit and no lymphadenopathy was detected. So my next question is, what other investigations would you like to order for this patient, and how will you work her up further?
So again, as I mentioned before, I would put number 1 is an infective cause of the generalized tonic-clonic seizure. So I would proceed with lumbar puncture after I ruled out any absolute contraindication for lumbar puncture. So as we know, if there's any no space-occupying lesion from the CT brain, then I'll proceed with the lumbar puncture to measure the opening pressure and send for biochemistry cultures recipe panel, and also autoimmune panels. And yeah, not to forget the urinary pregnancy test. The patient is in a reproductive age group, and to send for urine toxicology to look for any positive substance usage. And as mentioned from the history, patient is taking sodium valproate, and the history of non-compliance to the previous anti-seizure medication. So I would like to know on the level of the sodium valproate in the blood by sending the TDM. And as patient presented with a history of fever, I want to send blood culture and sensitivity, followed by infective markers, namely ESR and C-reactive protein. And also I would send for complete viral screening, HIV, Hep B and Hep C, and also Hep B core, because this can may aid later on in terms of if the patient need immunosuppression, if the patient had any autoimmune disease. And connective tissue screening, although the patient clinically doesn't have any CTD features, but in an atypical presentation of a young lady with an uncontrolled seizure, I would like to explore more on any vasculitis, cause of the seizure by sending autoimmune screening, namely ANA, ENA, double-strand DNA, the complements, and the ANCA. And not to forget sending the antiphospholipid panels. And last but not least, the anti-NMDA receptor antibodies, because the patient also had the background history of psychiatric disorder, bipolar. So in a patient with a background of psychosis, seizure, and then I would like to entertain on anti-NMDR receptor antibodies.
Just a note, sorry, Dr. Farhan. I think in the first slide that you showed, you were given the CT scan of a patient, right? So the CT scan, can you just recap what did it show?
Yeah, so the CT scan, the plain CT brain shows there's a left frontal lobe intracerebral hemorrhage.
Yes. Yeah. So would you proceed to do a lumbar puncture with the hemorrhage?
Usually, no.
Yes. So we have to tailor according to what the scan shows.
So yeah,
okay, good.
These are the blood investigation I would like to offer if before I get the imaging. Yeah. Okay. Then moving on for the more sophisticated imaging. So we go from the basic ECG first to look for any arrhythmias which may also trigger the seizure. Ultrasound renal Doppler to look for any renal artery stenosis, part of the investigation for young hypertension. And also I would like to look for a contrast enhanced CT brain and to look for any space occupying lesion or any abscess which may not be visualized in a plain CT brain. And again, to look hard for the cause of the left frontal hemorrhage. I want to know are there any atriovenous vascular malformation or any aneurysm which caused the bleed by ordering a CT angiogram or CT venogram. And again, advanced imaging like MRI, MRA, MRV of the brain to look for any features of encephalitis or vasculitis. And as mentioned before, one of the differential is anti-NMDR receptor antibodies disease. So usually it's related to paraneoplastic usually is related to a teratoma. So I would like to order also a CT-TAP to rule out any solid organ malignancy. And again, since Dr. Tan mentioned just now, the last EEG was about 5 years ago, which shows normal. So this time around, patient presented with a new onset of a GTC. I would like to repeat again the EEG to look for any new wave patterns. And again, another advanced imaging is a cerebral angiogram in the mode of digital subsection angiography, again, to look for any abnormalities in the cerebral vessel. And lastly, the echocardiogram to look for any vegetation or intracardiac thrombus or mass, which also can lead to cardioembolic stroke and also intracerebral hemorrhage.
Okay, that's a very extensive investigation. Thank you. But if you're the registrar on call on that night, right, and you call up Dr. Leong, right, you can't order for the whole battery of radiological investigations. So if you're given one chance, which investigation will be most helpful?
So as mentioned in the earlier slide, I already have a plain CT brain which shows a left frontal hemorrhage. So I would like to know any vascular anomalies there. So the most visible part to do during on-call time is the CT angiogram of the brain to look for any AVM or aneurysm.
Okay, thank you. All right, so Dr. JK will tell you about the results.
So thank you, Farhan, for a very extensive battery of tests being ordered. So I'll try to answer each of it one by one, whatever we have done. So TDM valproate was understandably below therapeutic range because the dose given was mostly to manage the bipolar disorder. Urine FME did not show any abnormal cells, and the urine PCI was normal. The blood culture did not show any growth. ESR was slightly elevated at 48. CRP was 6.8. C3 and C4 was within normal range. HIV, B surface antigen, and also anti-HCV were non-reactive. The ANA was markedly elevated, which is of more than 1 in 1,000 dilation with centromere pattern. AMA dsDNA was otherwise negative. The extranuclear antibody testing was positive for anti-centromere protein B or CNPB. The ultrasound renal Doppler did not show any evidence of RAS, and otherwise, in terms of additional tests such as ANCA, we were not able to send it because the patient's family members could not afford it. So again, the next question, we move on after knowing all this clinical examination that we've done. Oh, sorry, we didn't do an EEG, by the way. So what are the possible differential diagnoses that you can now narrow down based on what you have previously written without knowing what the additional history and investigations were?
So again, without the brain imaging, of course, based on the history and physical examination, again, I would go for meningoencephalitis as a first line of diagnosis. And then again, in a patient presented with a seizure and clinical examination show left hemiparesis, of course, acute stroke need to be ruled out first, either is ischemic or hemorrhagic. And then again, moving on to the later differential diagnosis, I would like to entertain about the autoimmune encephalitis or paraneoplastic panel in the background of patient having history of psychiatric disorder. And as mentioned in the history, patient is a non-compliance and defaulted anti-seizure medication in the past. So this could be just a simple breakthrough seizure due to non-compliance of the anti-seizure medication and provoked by infection. And another differential to entertain is a cerebral venous thrombosis. And I think the list is a metabolic toxic electrolyte imbalance and idiopathic intracranial hypertension, given the background of morbid obesity in a young lady. And again, but I put the first three based on the clinical presentation and also physical examination without the imaging. So after the preliminary plain CT brain was done, so again, the differential either is a acute stroke, hemorrhagic stroke, or autoimmune encephalitis.
Okay, so we'll invite Dr. Leong up the stage to present the radiological findings. So as you can see, there's a very extensive list of investigations done, right? So from the onset, and then I think there was follow-up scans.
Okay. Hi, morning. Leong here. So I'll go through the imaging that we have. So as Prof. Tan said, you see we have a long list here. So usually we start with the easiest and the least invasive ones, and also the fastest. So you can see that we always start with a non-contrast CT brain. And when we detected something, then we move on to a contrasted one. We can time it to do a CT angiogram where you specifically look at the arteries, and you can time it a bit later. You can look at the veins, then that is called a CTV. And subsequently, we also have another CT scan plane, non-contrast, to assess the progression of the bleed, and followed by more invasive, but give us more information, imaging study like angiogram. The proper name is called digital subtraction angiography. And lastly, the patient was also sent for an MRI brain with vessel wall imaging. Okay, when the patient was presented, there was also headache. Okay, and unfortunately, we are unable to pick up anything. So at this point of time, actually, patient has already complained of headache, and that means something is there, something is brewing. It's just that our imaging capability, for now, we are still unable to decipher what is happening. If we could pick this up earlier, then probably we can prevent the bleed. So 2 days later, this happened.
Okay,
Okay.
maybe we invite Dr. Farhan to just quickly explain.
Okay. This is a plain CT brain done on presentation. As you can see, there's a hyperdense lesion over the left frontal area here. So with a surrounding perilesional edema. So this is the intracerebral hemorrhage. Sorry. Again, there's no mass effect.
So why do you think a repeat CT brain was done? I mean, most of us have headache, including our head of department, right? But we don't repeat the scan for her. We don't even want to do a CT scan for her. So yeah, so this lady, first scan was normal. How often is it you will repeat a scan for a patient with a persistent headache?
Yeah, so usually if there's any new symptom or worsening symptom as well as a new neurological deficit. So I think the 2 days prior to the admission, it's just a headache. And this time around, patient came in with a seizure with a left hemiparesis. So I would like to know whether there's any new pathology inside the brain. That's why we repeat the imaging.
So good. She has new focal deficit and she had worsening of seizures. So hence we did a CT.
Okay, so when we look at this CT scan, I'm giving you the selected slices, showing you the most prominent part of the finding. So as Dr. Farhan mentioned, so when you see something hyperdense like this, so this is the density for an hemorrhage. So it is less than the bone, as you can see. And typically, if you see any bleed, there will be this perihemorrhagic edema. So this is the telltale sign that this is a bleed rather than some people may call it soft calcification and all. And I would like to add, actually, there's this already mass effect. So this is where the forks is. You can see that the forks was already pushed to the other side. So this is what we call the subfalcine herniation. Okay, it is not the generalized midline shift that you usually see. So this is very focal in front. Okay, and because it's going beneath the forks, and if this gets worse, patient can actually get bilateral ACA infarct, where it compresses on the ACA. Okay, yeah. So when we look at the bleed at this location, so this is nothing classical of a hypertensive bleed. So anything other than a hypertensive bleed, which classically at the basal ganglia, your brainstem, and also your dentate nucleus at the cerebellum, you have to exclude vascular cause, because vascular cause most of the time are treatable. For example, EVMs or aneurysms. Okay, so we have to do a CTA immediately.
Okay, so Dr. Farhan, you want to have a go? Or you just point out where is the abnormality? Maybe it's easier.
Not too sure.
Okay, now we'll let Dr. Leong
So
explain to us.
this is the CTA. So basically, this is a normal scan where we don't see anything significant. So the original image wasn't like this. So I have done some post-processing we call the MIP. Okay, we basically we make the vessels thicker, so it's easier to be seen for the eyes. Okay, so I try to highlight around the bleed that you can see actually you don't see any abnormal vasculature around it. Okay, so there is no significant abnormal vessels. But retrospectively, if you see here, it seems to me like there's a dot there. So probably that was the source, because there must be a source. Okay, it's just that whenever we scan the patient, most of the time the bleed has stopped, so we don't pick it up. Just like a burst, something ruptured, bleed, and then it stops. So if you retrospectively, I saw that there's a very faint hyper and enhancement here. That probably one of the vessels that ruptured was located here. Okay, so I'm showing you the full video of it. In case you don't believe me that the vessels are normal. So you can see that they are symmetrical. Yeah, you don't really see any asymmetry in the vessels. Okay. Then we move on to digital subtraction angiography. So what do we mean by digital subtraction angiography? So if you have seen the cardiologist do angiogram, you see the heart pumping and the contrast was injected. So that one is a digital angiography. They don't subtract away because the heart is just moving too fast. There's no way you can take away the bones and all the subtraction means you take out the background. Okay, but we are doing brains. We have scalp, okay, and the patient is not moving. So we basically acquire two images. Okay, the first one was the empty one, and when we inject contrast, the images will subtract the original one, so the bones will be removed, and what we get is just pure vessels. That's why the clarity is very high, and it's also very high spatial resolution. So this is the area of interest is on the left. So this is the left internal carotid artery, where I'm showing you this is the AP view, as if we are looking at the patient. This is right side, this is left side. So this is left ICA. And this is the arterial phase, and this is the capillary phase where the brain parenchyma is being opacified. And this is the venous phase. So at one glance, we don't see any abnormal vessels. So vessels usually taper, okay? Moving from the neck towards the distal end, they taper. And you should not be seeing any extra clumps of vessels. So this is the lateral view of the left ICA. Again, one glance, it looks rather normal. You don't see like an extra clump of vessels that you can call AVM. You don't see any big veins that you can call, probably this is AVF. And this is the venous phase. Okay, but when we zoom in, can you see the difference between here and here? Yes. So this is the how angiogram can help us, because angiogram is actually among all the imaging that we have in radiology, it is actually as good as chest X-ray. Actually, X-ray is very good because it has the highest spatial resolution, where you can zoom in and zoom in and zoom in. You can see very fine details. So using that technology and you inject contrast, then we get an angiogram. That's why you can see the very subtle, but it's actually quite obvious if once you see it, you cannot miss it anymore. Okay, there are more. See, irregular vessels. More. You see, this is small. As I said earlier, vessels should taper. It becomes big again. Okay, so this is the ophthalmic artery. You can see at the origin is very narrowed, and then it becomes more dilated, which is the normal one. Okay, so using the same angiogram, there's a method that we can actually do a CT scan using the angiogram. So this is called CBCT or cone beam CT, like our dentistry colleague, the cone beam CT for the tooth is more or less the same, but this is the bigger one. So by injecting contrast, we actually can create a CT scan from the angiogram. So this is the image that we acquire. Can you see? Narrowing. This is along the ACA. Okay, very beaded looking. The ophthalmic artery, which I showed earlier, narrow and then becomes more dilated. Here, this is more dilated. This is narrow. So it's everywhere. So also, using the same left ICA injection, we can produce this. This is what we call a 3D rotational angiography. The images are not so clear here because when I transfer the image, it looks a bit bad. But on the console, it's really, really clear. Okay, and from here, you can also appreciate there are multiple areas of narrowing everywhere, basically the whole brain. And this is just the left ICA. Okay, let's move on to right ICA. So you see multiple narrowing of the vessels on the left cerebral hemisphere. You may say that, oh, there's a bleed there. It could be just vasospasm. All right, then we look at the right side. One glance, again, it looks rather normal. But if you focus at it, this is rather small compared to distally. It becomes small and more dilated. This is not a normal caliber of an MCA. This is very stenotic. Okay, we look at the lateral. Again, you see big caliber, small caliber. Ophthalmic artery again, small, big. It's everywhere. Yeah. And we look at the posterior circulation. At one glance, it's also no AVMs, no AVF. But there are multiple areas of stenosis. Yeah. So conclusion for the diagnostic imaging, we have CT scan, which show this is an atypical location for hypertensive bleed. So we should really hunt for a vascular cause. And CT angiogram shows that there's no aneurysm, no AVM, no tumor, no signs of infection. And from the DSA, we can confirm that there's no AVM, AVF, and no aneurysm. And the most significant finding is actually multi-territorial alternating stenotic and dilated segments. So the final diagnosis from imaging point of view is vasculitis. So these are a few learning points. When you see an atypical location of ICH, think of other differential diagnoses and always exclude vascular cause, because vascular cause can kill. It can also be treated. So DSA has the highest spatial resolution where we can see fine details. DSA is actually a luminal imaging. We're actually looking at the lumen, but the problem is actually on the vessel, correct? Vessel wall, yeah. So we actually infer from the state of the vessel based on the lumen. So technology now has progressed, and now we can study the vessel wall, and this can be done using MRI vessel wall imaging. Should I tell the progress first, or we continue? Okay, we just continue. So patient just had a repeat MRI 2 days ago. I'm just showing you one section of it. So this is the posterior circulation. This is the basilar artery that I showed earlier. So 2 months down the line, you can see that it has already resolved after treatment has been given to the patient. This narrowing, normalized. This one, all normalized. Yeah. So this is the vessel wall imaging. I'm just showing you 2 sections of it. So what we do, if you see the normal scans like CTA, MRA, all the vessels are light up, meaning the vessels are usually very bright, just like CTA. Yeah. But in vessel wall imaging is different. What we do is actually we suppress the signal inside the vessel. Okay. At the same time, we give contrast. What we want is we don't want the signal from the lumen, but we want the signal on the wall. And the wall is actually something very thin. Okay. So using this method, we can see the enhancement of the wall of the vessel, and they will the different pattern of it will give us different diagnosis. So for this patient, there's no abnormal vessel wall enhancement. So most likely because treatment has been given. We didn't do the scan in the acute phase. And this is the hematoma, which is slightly smaller. This one will take months and months to resolve. So not related to this case, just want to show you a good example of how vessel wall imaging can be used. So I had this case probably last year or last 2 years. So we have 2 aneurysms. Yeah, this is the PCOM. This is the anterior corridor. We got the bad SAH. The question is, which one is the culprit? Okay, if you are doing a open surgery, clipping by surgeon, they will open up. They can easily see which one. But if for us, we do endovascular, we repair from inside, we have to be sure which one. Okay, so we cannot tell. Both more or less the same. So this is where vessel wall imaging helps. As you can see, this is the vessel. This is the left ICA. There's one bump here, one bump here. Just believe me, okay? It's not very clear because after I export the picture. So after we give contrast, you can see that this bump here actually light up. So this is a pituitary stalk. This is a pituitary stalk, which is normally enhanced. There's some enhancement here, the first bump. So the ruptured one was this one, and this was confirmed intraoperatively. Yeah, so this is how vessel wall imaging can help. Okay, thank you. Next to Prof. Sherry.
All right, thank you, Dr. Leong. Just a question. I mean, we don't do DSA routinely for all vasculitis patients, all right? So are there certain criteria that you will go ahead to do DSA, or just you're happy with just an MRA or MRI?
As I said, when the first line is always a CTA, okay? Because what we want to exclude is definitely an aneurysm. It could be a mycotic aneurysm, and AVM, and also AVF. Most of the time, these 3 can be seen on CTA. However, the gold standard to exclude this is still DSA. So I don't simply do angiogram for anyone, but if there is such case, I will happily do it. Because the gold standard to exclude AVM and AVM is still angiogram, and they are we have patients what we call they have this micro AVM, which is even less than 1 centimeter. Yeah, that can only be picked up from angiogram.
Okay. Right.
Yeah.
Thank you. Thank you. So
It's
I
case to
think
case basis, Prof.
that's right. Yeah. So we will usually discuss with Dr. Leong whether it's you need further investigation. So CTA first, huh? All right. So next we have like to invite Prof. Shari to present the CNS system and rheumatology. Yeah. Okay.
Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin. Wassalatu wassalamu asyrafil anbiya wa mursalin. Wa ala alihi wa sahbihi ajma'in. Rabbi shrah li sadri yassir li amri. Wahlul 'uqdatam min lisani yafqahu qawli. Thank you for inviting me for this very important CPC presentation. Now, in CNS, involvement in rheumatology is not going to cover a lot about all the specifics of the diseases in this event. But if you were to look back at the patient, she's asymptomatic for virtually everything, and the diagnostic tool that clinch the diagnosis is imaging, and so is the management of CNS in rheumatology. There is no blood markers that can assist, no C3, C4 that can assist, and therefore it depends a lot on clinical presentation. And of course, we are not going to wait for a recurrent seizure to do any urgent imaging, and our only hope is to monitor them using blood vessel monitoring as depicted just now. Now, the pathogenesis of CNS is virtually involving the vessel. Now, if you were to recap again the antibody, very strongly positive for anticentromere, which is quite specific for your scleroderma. Because she's obese, I suppose it's difficult to find out whether there's any sclerodactyly or tightening of the skin involved, but there's nothing very surprising if you talk about scleroderma in such patient, because scleroderma's theme and pathogenesis is virtually vasculopathy. Anything involve the vessels. So if the vessels is weak, then we have to blame it on scleroderma when we talk about anticentromere high positive titer, 1 in 1,000. And CNS at the same time in rheumatology is because we are playing a lot on biologics. We're also having these side effects of certain biologics. And the one that is really sad is rituximab treated patients. They get this progressive multifocal leukoencephalopathy, a demyelinating disease of the CNS. And that's why, although it is a breakthrough treatment in SLE, for example, it's quite difficult to say that you can maintain it every 6 months and hope that nothing happens. So there are various protocols involved now whereby we might give rituximab in the 2 cycle, 1 gram, 2 weeks apart, and then repeat it every 6 months. But we might not go full dose. We might just give 500 milligrams of rituximab maintenance every 6 months. So that one will depend on the patient itself. And other benign things like headache for tocilizumab, anakinra, and abatacept, all these things are not worrying, except that if you talk about headache and immunosuppression, you're worried about any fungal infection or space-occupying lesion in the brain. So we tend to overdiagnose patient by sending them for a CT scan in the end. So this one has been mentioned earlier just now, and a bit about APLS antibodies. You must repeat it. You must repeat it twice, around 6 weeks apart at least, and then you have to repeat because these are very volatile and it changes its titer, and we only have positive and negative in UKM, whereas we have to measure the titer of each antibody of anticardiolipin, beta-2 glycoprotein 1, and lupus anticoagulant. Now, the only antibody that we cannot do if the patient is on heparin or anticoagulant is lupus anticoagulant. Anticardiolipin and beta-2 glycoprotein 1 can still be repeated, and hopefully we get a significant titer. Serology, as I mentioned just now, angiotensin converting enzyme is for sarcoidosis, And anti-endothelial antibodies is a antibody which is roughly associated with vasculitis around across the board. Never forget infection. Infection also may mimic vasculitis, such as your syphilis, hepatitis B, hepatitis C, borreliosis, retroviral, and tuberculosis. These are infamous infections that we might have to rule out first before we can commit to immunosuppression. So we have to have a CNS presentation in many sense, but for rheumatology disease to be diagnosed, we need both the serology and clinical criteria at the same time, except for primary vasculitis. So once a treatment is started, then we have to prophylaxisly cover them with pneumocystis jirovecii, prophylactic one, tap Bactrim once a day. But that again varies from patient to patient. Some people develop renal failure, liver function problems, and things like that. So it is a case-to-case basis. But being on immunosuppressants for a long term, at least 6 months, and, and many times that we use cyclophosphamide or rituximab. Now, rituximab is unfortunately quite expensive and requires a lot of financial support for the patient, for the relative of the patient, and so on. That's why you have to go to cyclophosphamide. But unfortunately, cyclophosphamide can give rise to premature ovarian failure, which is not really suitable for this lady. But then again, proper counseling can help. And although not many people are using this service of ovum preserving service in UKM, but the protocol to preserve the ovum is also can give rise to a flare of the rheumatology disease because they need to induce hyperstimulation of the ovaries and then keep the ovum for safekeeping until proper time for the patient to get pregnant. Because once you're on cyclophosphamide, your ovaries will get affected indefinitely. So again, proper counseling must be there. Family discussion regarding the explanation of the length, type of treatment, and complications of treatment must always be forwarded. And whether we like it or not, we can't really come up with a suitable plan in such young patient. But again, if we need to give cyclophosphamide, then I suppose there's no reason not to give, because her extensive involvement of the vessels is generalized, bleeding and so on. And that is already a telltale sign that it might reoccur again in the near future. Not to mention about breastfeeding and pregnancy. So this is again something new. We always thought hydroxychloroquine is safe for everything, everybody pregnant, postpartum, breastfeeding. But however, now because of audit in various countries, they found that it causes minor deformities of the child. For instance, cleft palates and so on. So it may not be that safe anymore. So this is an event where we have to discuss with the patient that although benefit outweigh the risk, but the parents have to be aware that hydroxychloroquine can give rise to such minor defects of the baby. Thank you.
Thank you, Prof. Shari. Yeah. So you listed there a lot of investigations, all right, and pretty much sometimes in the wards, would you treat the patients clinically before all these investigations come back from the lab? Because sometimes it takes a few weeks, right? Yeah.
That's a difficult question to answer because ANA is overprescribed most of the time, and it's difficult sometimes to accept the fact that it may or may not be a rheumatology disease. Right now, even young psychiatry patients are being ordered ANA. Not to mention neurology, respiratory, orthopedics, and so on. Therefore, the diagnostic tool is going to be overprescribed, and we might be detecting patients who are not having rheumatology disease. Now, again, to treat patients by clinical, I suppose that's the gist towards medicine at the end of the day. But we need to trust our judgment in the sense that immunosuppressants are not really safe drugs. Once you are given it, then the whole body becomes immunocompromised, and infection, especially from the wards, you can get it very easily. Now, I personally have whenever I read a report, Leong, whenever I read a report beating, I get excited and I start to give immunosuppressant until they discuss it in the neuro conference on Tuesdays, and it's artifact. And I've given like 3 days of 1 gram methylpred, and I can't suck the methylpred back. So in that sense, I still depend on the trial. I would say a trial of steroids that maybe the steroid will improve the patients in the short run after the steroid pulse of 3 days. And in fact, now it is proven that high dose steroid is now dangerous already. KKM in Malaysia used to laugh at our 250 methylpred pulse, but now people are having a change of paradigm that high dose steroids may be detrimental to the patient's well-being. But to answer the question is that I will still go for hard evidence before I commit to start the treatment.
Okay, thank you, Prof. Shari. So the final presenter is Dr. Tan Jun Kim, neurology trainee from the department. So Dr. Tan will wrap up the history and everything. All right, thank you.
Okay, so I'll focus more about vasculitis since we're running short of time. Basically, vasculitis means the inflammation of any part of the blood vessels, and that could range between arteries, whether it's small, large arteries, whether it's capillaries as well, or even the veins. So Younger et al. In 2003 has actually given a quite good graphical description about what kind of systemic disease could have vasculitis and where the range of vessels will be involved. So in terms of CNS vasculitis, they can actually affect quite a large spectrum from the medium arteries, the small arteries, up to the veins itself. So I'll focus mostly on primary vasculitis, which is also synonymously known as isolated vasculitis or meningitis of the CNS. And when we mean CNS, basically the central nervous system will include the brain, the spinal cord, as well as the leptomeninges. So any part of this involved will be primarily a CNS vasculitis. So what happens is literally inflammation of the immune cells, which is usually forming a cuff of lymphocytic infiltrate around the vessels, which leads to multiple areas of scarring and thickening of the tissue, which causes stenosis. And sometimes, in certain cases, when there is cell loss, it causes wall thinning, and eventually it leads to an aneurysm. So it's very important to have a high index of suspicion in these patients because they can present with a myriad of symptoms. Basically, they can come with headache, they can come with cognitive impairment, which we think may be normal in certain people, seizures, focal deficits, which may be more severe, like paresis, dysphasias, or ataxias. And usually they have a very gradual course, but eventually they present with an acute presentation, such as our patient. It's also very important to realize that primarily CNS vasculitis, when we're talking about primary meningitis, is pretty much a diagnosis of exclusion. So you do need to exclude other mimics as well, because there are many conditions which can also cause similar symptoms, such as infective causes like varicella zoster infection, reversible cerebral vasoconstriction syndrome, which is the main mimic RCVS for this condition, young stroke onsets like Cardiac MELAS, and also moya-moya angiopathies, which also requires TSA eventually, or a high resolution CTA. So the diagnostic criteria is a bit difficult to elucidate for a patient with CNS vasculitis because they largely revolve around an extensive workup to rule out systemic causes. But eventually, if you come across a patient with unexplained neurological deficit, especially someone who is a middle-aged man, which has got a slight higher predilection for CNS vasculitis, someone with a classical angiographic or histopathological features of meningitis, and someone with no evidence of systemic vasculitis, you may want to consider this diagnosis. And someone in 2009, Bernheim, actually suggested a modified criteria to simplify the diagnostic criteria, which is very simplified to definite and probable. Definite, basically, if you have got a tissue sample which is biopsy confirmed, and probable if you have an MRI or DSA that suggests the patient has got CNS vasculitis findings, like explained by Dr. Leong earlier, with suggestive CSF findings. I'd like to stress this point because CSF is still important in this patient, assuming that the indication is present and there are no contraindications such as outpatient. Because a large number of patients with CNS vasculitis primarily have an abnormal CSF biochemistry, they largely come with a markedly increased protein level as well as pleocytosis, which is lymphocytic predominant, and their blood results are usually rarely abnormal. MRI, MRA, DSAs will usually find the typical findings explained by Dr. Leong, but most studies actually suggested to get a tissue biopsy, which could involve the leptomeninges or even the brain, usually the left frontal lobe, which is the least eloquent area. Studies have shown that before this past retrospective data shows that brain biopsies were quite safe. There were no untoward sequelae in the patients that have undergone the procedure. But I imagine it'll be a bit difficult to get a consent for brain biopsy in Malaysia, where even getting a consent for LP will be a bit difficult already. So usually the tissue biopsy will show some granulomatous lesions with lymphocytic cuffing around the vessels, which is seen around this area, this side. But I'm not a histopathologist, so I'm just following the description for the picture. So they also have acute necrotizing patterns, which is not seen in this picture. So management, as Prof. Sherry has mentioned, revolves around immunosuppression, and immunosuppression is key to retard the progress and also minimize the long-term sequelae. But it is important to note that in CNS vasculitis, there is really a lack of randomized controlled trials to actually depict what will be the best management. So we are adopting most of the guidelines based on systemic vasculitis treatment, and that will include giving corticosteroids and concurrent cyclophosphamide later on in acute presentations, and then later on we maintain them on immunosuppressants, which is steroid sparing, such as azathioprine, methotrexate, and also CellCept. This patient actually had a short course of IV methylprednisolone, given about 3 days, and then subsequently she is now on a tapering prednisolone dose with further plan to give, to convert to a non-steroidal agent. Otherwise, in terms of biologics, we can consider rituximab, anti-TNF agents such as infliximab and etanercept. And of course, it is important to manage the symptoms which patients present with. For example, if a patient presented with seizure, you need to know how to manage the seizure optimally. And that's why I think in looking at the general population of the audience, I think it's important to revise the seizure first aid management, especially for medical students. So I don't have the time to go through everything, but I will invite you to take a picture. So this is one of the occasions that you probably can take out your phone and take a picture, because it's not every day you get a patient with seizure. But yes, you do need to know how to manage these patients. And the typical main points, which is important for a patient who is not on a wheelchair or on a wheelchair, is basically to keep the patient safe, stay with them, and also to put them on your side. And also there's this part at the bottom that actually tells you when you should call 911. So not every patient with a seizure requires you to call the emergency services. But I'd like to stress the point of 5 minutes. If a seizure lasts longer than 5 minutes, why is it that we call 911 if the seizure lasts for more than 5 minutes? So Professor Eugene Schrinker actually bring up quite an important point. This was published in ILAE in Epilepsy. Basically, seizures are dangerous beyond 5 minutes because we are dividing the seizures based on 2 operational dimensions, where T1 actually suggested that if the patient has got a seizure beyond this period, they are more likely to have a continuous seizure. And T2 suggests that beyond this period, they are more likely to have neuronal injury, neuronal death, and also long-term sequelae. So in the case of tonic-clonic seizures, such as our patient, if she has got a seizure of more than 5 minutes, it's likely that she will continue to have seizure beyond this period, which will require more advanced treatment facilities or a basic midazolam or diazepam, which can be intravenously given, rectally given, or even intramuscularly given. And beyond that, 30 minutes later on, we will expect some long-term sequelae, which may eventually lead to some mild cognitive impairment. And this may differ from the different types of seizures as well. So the management, basically, if you were attending to the patient in the emergency department, or if you're in a hospital setting, it largely revolves around trying to stop the seizure. If you cannot get a line for the patient, you might want to consider giving the patient IM midazolam first or rectal diazepam. And if you do have one, you can go for the conventional IV midazolam. For prevention, usually we also load the patient with few different anti-seizure medications, for example, phenytoin, valproate, and levetiracetam, whichever is available to you. But most importantly, it's important to investigate and also treat the underlying cause of the seizure, because we don't want it to recur again in future. I think that's for my part. Thank you.
Okay, thank you. Do you know what happened to the patient? Dr. Tan would like to tell the audience.
So I know that the patient has improved clinically. She's actually still on her tapering dose of prednisolone, and she's recently been admitted for an elective MRI, which was done and shown by Dr. Leong earlier. So we did find out that the ANCA levels were not sent because there was some issue with payment. And right now, I think there's counseling ongoing on trying to switch her to non-steroidal immunosuppressant, which is a bit difficult as well due to some apprehension by the patient.
So the patient is still on steroids?
Patient has been discharged as of now from surgical ward, but patient is still on tapering dose of steroid. Yeah.
Okay, so we will probably need Prof. Shari's team to manage her. Yeah. Okay, so we'd like to open the floor to any questions. I also like to thank Dr. Ratika actually for actually she handled this case very well over the weekend. So all these investigations was ordered through in the weekend actually. So it's easier to get the battery of investigations with Dr. Leong's help, of course. Okay, any questions from the students or the doctors? Yeah. If not, as I promised Prof. Sharul that we will end the CPC 5 minutes earlier so that the medical students can do this quiz, correct? Yeah. Okay, thank you everyone. All right, enjoy your day.
So point Isha, can we move on to the quiz for the students?
Yeah, students stay back. Apparently there is a grand prize at the end of the year if you can score full marks for the CPC.